Good morning, everyone, and welcome to the third webinar organized by the European Connected Health Alliance Thematic Innovation Ecosystem on Integrated Care. My name is Andrea Pavlikova, and I am International Engagement Manager with the Scottish Government, and I also have a pleasure to chair this innovation ecosystem. So the topic for today's webinar is innovative delivery of services for long COVID patients. And in particular, we will be featuring two examples in Greece in the cities of Athens and Thessaloniki. So in terms of the agenda, we will make a quick introduction to the thematic innovation ecosystem itself, followed by 4 distinctive speakers from Greece, and then we will have a dedicated discussion. But please feel free to pose your questions in the chat as we go through throughout the webinar so that we can pick up on your questions in the discussion itself. So without further ado, I'll hand over to Andy to give you some more words about the European Connected Health Alliance and innovation ecosystem on integrated care itself.
Thank you very much for that, and thanks to colleagues from Scotland for kindly again helping to organise and open this session. I want to be very brief today. My name is Andy Bleeden. I work for the European Connected Health Alliance. We are a large community of members and partners, and we bring those together in our ecosystems. Many of you are familiar with the concept. I'm not going to labour the concept with you today. It's around matching need and solution. And we're going to see some of that today from colleagues from Greece on this exciting topic of how to work with the area of long COVID. Just so you understand, our ecosystem network has grown over the last 11 years now. Certainly, it's grown at a rate we're very, very hard to keep numbers of. It's grown now to an ecosystem network of over 70 ecosystems across the globe, all of whom have been struggling with both the pandemic and how then to deal with long COVID, which is having an impact across all of the ecosystems that you can see in front of you. Our network asked us, the ECH Alliance, to do something more collaborative within our network as it grew. So we came up with the concept of developing thematic ecosystems. These would work with our ecosystems, led by our ecosystems, and more importantly, our members on a variety of different topics. And you can see the ones in lighter blue that we launched last year, including this one on integrated care. And obviously, we're growing our ecosystem network this year in a wide variety of areas, such as continence and telemedicine and health inequalities. And the last thing I'll say to you is we hope by the end of this year to launch 2 others. One will be on the menopause, and the other will be on the topic of cancer. I'm going to stop talking now because I want to get on with the subject matter for today, which is to hear from our speakers from Greece. Now, we have a number of speakers from Greece, all of who have got an expertise in this field. Some will be from the need side, and some will be there in terms of giving examples of best practice. So enough from me. I'm going to hand over now to Professor Nikolaos Koulouris from the Athens Medical School. Please, the floor is yours.
Okay, good morning to everybody. Okay, can you see my slides? Yes. Okay, 2 years after the onset of the COVID-19 pandemic, the scientific community is facing a new systemic syndrome known as long COVID syndrome. Our knowledge about long-term COVID at scientific and socioeconomic level is disproportionately limited in relation to the widespread size of the problem. According to the World Health Organization, patients with COVID-19 infection are more likely to develop fatigue, cardiac, respiratory, neurological, and psychiatric symptoms for some time after the initial infection and have no longer medical explanation. There is evidence that patients, even with mild COVID-19, may complain about persistent symptoms several weeks or months after the infection. This suggests the symptoms during the infection may not resolve spontaneously. The objective of this study, as you see on the screen, was to assess whether multiple relevant symptoms recover following the onset of symptoms in hospitalized and non-hospitalized patients with COVID. This article showed the presence of 29 symptoms at the time of the onset of symptoms and at follow-up. The median number of symptoms developed during the infection is reduced significantly over time. In this slide, patients with coronavirus disease or post-COVID will probably have a need for rehabilitation during and directly after the hospitalization. In this study, 93 experts were asked to fill out 13 multiple-choice questions, and agreement of directionality was tabulated for each question. More than 70% agreement directionality was necessary to make consensus suggestions. Experts recommend identification of unmet rehabilitation needs in patients with COVID-19 who are discharged from the hospital and consequent tailored rehabilitative interventions accompanied by compliance with the highest biosecurity standards. So here you see an ERS, European Respiratory Society, and American Thoracic Society guidance suggested the care pathway and recommendations were made during the hospital stay and 6 to 8 weeks after post-hospital discharge. They recommended in hospital stay, bedside rehabilitation, and oxygen requirement at rest and during exertion. But following discharge, they recommended regular physical activity, low moderate exercise at home. 2 months post discharge, they recommended physical and emotional function, assessment of quality of life, anxiety and depression, assessment of respiratory function, measurement of exercise capacity, and establish the need for rehabilitation. The pulmonary rehabilitation program consists of comprehensive rehabilitation, aerobic exercises, muscle strengthening programs, nutritional support, and psychological support. In Soteria Hospital in Athens, we have established a University Pulmonary Rehabilitation Unit since 2009, especially for COPD patients. Our multidisciplinary rehabilitation program consists of phase 1, and this includes initial 4 weeks outpatient pulmonary rehabilitation unit twice per week, interval aerobic exercises, cycling at 70% peak WR max, resistance exercises, session with multidisciplinary team specialists. And also the telerehabilitation phase, because our program is an hybrid program, it has an initial phase done in the hospital, and the telerehabilitation phase, which is offered 3 times per week, and it includes aerobic exercise captured by an application installed in the smartphones for the patient, weekly contact with the rehabilitation team, and session with the team specialists if needed. Also, we do data collection. We have a lot of data, personal data, medical history of the patients, the physical examination, laboratory data, mental status and quality of life measurement scores, anxiety and depression scores, respiratory function, respiratory peripheral mass strength measurements, exercise tolerance and functional capacity, and heart ultrasound findings. So our preliminary results show that exercise tolerance increased after pulmonary rehabilitation, fatigue reduced, the quality of life was improved, mental health was improved, and functional capacity in general was improved. And you see this table, some of the measurements we made, but all of them show an improvement. So, we seek for national and international collaboration and the appropriate tools, so we extend our service to offer home-based long-term care, to examine the sustainability of rehabilitation results, telerehabilitation for remote areas and support of the primary and social care, and smart healthcare, leveraging the data for patients' risk stratification and personalized care. Thank you for your attention.
Thank you very much, Nikolaos. So now we will move on to Professor Christos Savvoupoulos.
Okay. While I'm trying to share with you my slides, I would like to thank the organizing committee for this very interesting webinar, and especially my partner, my colleague, Dr. Votetsianos, who and also to congratulate him for his attention to bring out the Greek effort. And now we're ready to see the need for a coordinated care. And of course, people with long-term COVID need an individualized and holistic approach with interdisciplinary teams that ensure their recovery through the application on the structure protocols. And the management of patients with long-term COVID regards acute and potentially fatal situations, while upgrades the quality of life of all patients, and particularly vulnerable patients or vulnerable groups who are far from large urban centers, and people who face language or cultural barriers have difficult access to specialized care. In order to achieve the above objectives, the sectors of our university, of internal medicine, neurology, psychiatry, of our hospital is a HEPA hospital, which is a university hospital, came together to propose the creation of a long COVID scientific center, in abbreviation LCSC, integrated in the Special Basic and Translational Research Unit, the Biomedical Research and Training Unit of the Department of Medical School of Health Science of Aristotle University of Thessaloniki, with the following structure. The LCSC will be staffed with colleagues from other scientific fields and specialty, such as pneumologists, cardiologists, internists, general practitioners, and other specialties, who are directly involved in the management of COVID-19 cases. Also, physiotherapists, speech therapists, and occupational therapists, in order to provide specialized services to patients in a coordinated manner for their rehabilitation. The holistic approach, with reference to individual specialties and the general coordination of the above, will be undertaken by a board that will take over its management. And which are our targets? The first one is the establishment of a network of clinical trials for the treatment of patients. A second target is to develop the development of an educational project aimed at the transfer of a knowledge and the connection of clinical structure of a primary and secondary, public and private sector with a long-term COVID reference center such as HEPA hospital for the better treatment of patients both in hospital as well as at home. The development of research activities aimed at understanding the pathophysiological background of long COVID syndrome and the development of methods for their optimal treatment. And the last one, but not least, the development of structures for the provision of clinical services to patients with long COVID. About the structure and methodology, you can see that the selection, evaluation, and treatment of COVID-19 patients will take place in 3 consecutive phases. The first one is the screening, and this first stage involves scanning the population of interest by telephone with 3 subcategories of patients. First one is patients with COVID-19 infection, but there are patients who present to emergency department of our hospitals due to persistent symptoms of COVID-19 infection, but who did not require hospitalization. And the third one, for me, the vast majority of patients are hospitalized patients for COVID-19 infection after they discharge. The scanning phase includes the remote, telephone, or internet, depending, of course, on the technological competence of each patient, completion of a special design based on an international literature questionnaire that detects the main symptoms of long-term COVID. The second phase is a diagnostic evaluation. In this stage, patients selected as potential long-term COVID patients are referred for further clinical, laboratory, or imaging examination by the relevant scientific team corresponding to the symptoms detected. And the third one is for which we'll discuss probably in this webinar, the ICT supported therapeutic intervention. This stage concerns the monitoring, evaluation, and treatment with telemedicine methods of patients who during the stage of diagnostic evaluation were documented to suffer from clinical significant manifestations of long-term COVID-19. For this purpose, certified ICT software, of course, will be used that combines, on the one hand, the daily evaluation of patients, and on the other hand, a range of customized mental exercise and physical activities, as you have the chance to see in the previous presentation. That will be performed in the patient's environment. More specifically, the design of the center allows access to its services to vulnerable, as I have mentioned before, and sensitive groups of population, to people underserved with mobility disorders or with a psychiatric background, and especially to those far from large urban centers and people facing financial, linguistic, or cultural barriers. The operation, of course, of ICSC provides for the approach, examination, monitoring, and just a minute, okay, to have an holistic procedure. To make the long story short, in conclusion, the SCS provides an integrated monitoring and care based on accredited quality criteria and the use of the following services: video conferences, web-based electronic file, or in some cases, a brief patient file, as well as personalized treatment plans, transfer of biological parameters such as oximetry, ECG, etc., medical decision support, data analytics, artificial intelligence, communication and coordination of care, psychosocial social support, continuing education, early detection of complications. In addition, the NCSC, taking on an educational role, aims to alert health scientists about the diagnosis and rehabilitation of long COVID, as the symptoms that occur are diverse and mainly because often they occur in patients who did not need hospitalization during the acute phase of COVID infection. I would like to thank you for your attention, and I think that with these few slides, I have provided you with some data information about what we do or what we intend to do in our hospital. And of course, we will be so happy if we have partners in this frame. Thank you very much.
Thank you very much, Christos. So we will now move on to the third presentation by Dr. Theodor. I think you are muted, Theo.
Can you hear me now? Okay.
Yeah.
Okay. I'm trying to share my screen. Okay. So I'd like first to thank the organizing organizing committee, Adi, Andrea, Nessa, all the friends and collaborators for the opportunity that they gave us to present our efforts for this very vulnerable population, vulnerable patients having long COVID, and to discuss, to exchange ideas, to exchange experience, and to discuss our next steps. Just a few words about our network. It has been established as a scientific society since 2015, consisting from partners from academia, from public, from social care, as well as from private care, especially from ICT industry. In 2019, together with Municipality of Athens, we became a 3-star reference site of the EIP initiative of Europe. And so what is the meaning of our involvement in long COVID management? These are the main reasons. Long COVID management is comparable to the management of the chronic conditions, which is the main focus of our network. It is delivered in an outpatient setup. It relies more than rehabilitation and continuous primary and social support than on drugs or conventional medical therapies. And also it demands ICT and artificial intelligence supported services, as well as personalized care. Let me show you that from the beginning of COVID, the pure medical literature is full of recommendations for the usage of telemedicine applications. I'm occupied for more than 20 years of ICT-enabled care, and I have seen only the 2 last years so many recommendations from medical literature. You can see here from United Kingdom literature, from Italy, especially special recommendations for multiple reasons for this vulnerable population of patients. So what we are planning to do, we are in collaboration with Athens and Thessaloniki, and especially of Athens, and on the basis of what Professor Koulouris described for Sotiria Hospital, and in collaboration with the region of Attica, I think that the vice chair of the region of Attica, Dr. Kechris, is also present in our webinar. We have been discussing the design of a quadruple helix approach under the umbrella of the region, involving academic sector, public sector, mainly our hospital, a major public hospital, scientific societies, and of course, ICT sector. So we are planning in collaboration with colleagues from several other sites in Europe to apply the principles of integrated care in this population of patients. So to move from fragmented and hospital-centered care to outpatient and focusing on the integrated approach care. The region of Attica is willing to offer us all the infrastructure and resources as an umbrella to move to this new, to this advanced era of ICT-enabled care, what our friends and partners from Scotland say as health and care for. This is a brief but very vivid definition of health for, saying that is the way that people develop digital health and care services, focuses on trusted, integrated network of organizations, people and technologies, which would help people co-manage in the context of their own care cycle and the community. You can understand difficult things, but they are worth to try. These are the main components of our design. Here is the central focus of our design, the person-centered process with the main components in the center, taking very serious into account the values of each patient, each separate patients. And this scheme represents the specialized characteristics for this kind of patients. I wouldn't like to take more time at this level. I would, our design is at anyone's disposal that would like to exchange ideas with us. So I would give the floor to the next speaker, to Mrs. Iasionidou, that will describe what the patient expects from us. Thank you very much again for the opportunity to discuss all these efforts of ours with you.
Thank you very much, Theodore, for this impressive presentation. And as you mentioned, we will hand over to our last speaker, Eleni Iasionidou, and then we will open the floor for the questions. And in the meantime, just a reminder that you can still pose your questions in the chat. So Eleni, over to you.
Let me share my screen, please. Okay. Is it full? Do you see it as a full screen now?
Yep, we can see it perfectly.
Okay. Good morning, and thank you for inviting me to this webinar organized by your team. My name is Eleni Iasionidou. I'm a pediatrician, long hauler, president and co-founder of Long COVID Greece. The COVID-19 pandemic, based on yesterday's data, has so far affected 450 million people worldwide, with more than 6 million deaths. Countries have used most of their resources to manage hospital admission and prioritize vaccination, but the pandemic is, however, far from over. Many people struggle to recover from the acute infection, suffering persistent disabling symptoms of COVID-19, also referred as long COVID or post-COVID condition. Over 50 million people is estimated to struggle worldwide by this new condition, which affects their function, their ability to work, and their quality of life. Ayuk Pani and colleagues extract data from all UK GP records linked to hospital admission to explore risks of readmission, death, and morbidity. Strikingly, 1/3 of discharged patients were readmitted to hospital and 1 in 10 died. Similar multi-organ impairment have also been observed in low-risk individuals non-hospitalized for COVID-19 in a study by Dennis et al. Hospital pathophysiology implicates immunological dysfunction, mast cell activation syndrome, microclotting, and dysautonomia. This new condition that can present with more than 200 symptoms places a significant burden on healthcare systems, asking for integrated care rather than highly specialized one, which is usually seen in most of our countries. Okay. I'm trying to get to the next slide. I don't know why it's not moving on.
If it helps, Eleni, I can maybe try and do via remotely. I'm going to send you a button and it should say to allow.
Okay.
Okay.
Can we go to the next slide, please? No, the previous one. The previous one. The previous. No,
okay,
no.
Sorry.
Go back. Go back, please. Okay, this one. Okay, thank you. Okay. This is a timeline of our evolution. Long COVID Greece is the first and only patient association in Greece for people suffering from long COVID. Among our members, we have a lot of medical doctors, health sector workers, and researchers with 24 months of long COVID experience. Our association originated from our Facebook support group. Soon after we became members of Long COVID Europe and Long COVID Kids, we came in touch with WHO, medical societies, and the universities in our country. Our goal is to legitimize and communicate this new disease affecting us all, regardless of severity of initial infection and need of hospitalization. At the time being, we're in cooperation with the Ministry of Health to promote creation of integrated multidisciplinary referral centers for people affected by long COVID and the creation of a digital platform for data collection, registration, dashboard, and a platform for telemedicine. Next slide, please. Can we go to the next one? Okay, thank you. Acknowledging our needs. This is a survey conducted among our Facebook support group. Online questionnaires were distributed to a cohort of long COVID patients who are members of our patient organization. We used Google Forms, specially designed. The results were analyzed using a specialized statistical software. 208 patients answered our questionnaires. As you can see from the graph, 80% were female, and most responders fall within the range, within the age range of 41 to 50 years. The duration of long COVID symptoms were 7 to 12 months, or 45%, 1 to 6 months, 29%, and more than 12 months in 22%. Over here, the graph is a little bit, there is a mistake here on the graph. Regarding hospitalization and admission, 69% have not been hospitalized, 27% have been hospitalized outside of the ICU, while 1.3% only was hospitalized at the ICU. On effect on COVID element on employment relation, about 58% are faced with problems at work due to prolonged illness. Moreover, only 12% of the respondents were attended by public hospital, while 88% were not. With respect to the number of medical resources used, 42% have visited at most 2 different doctors, 42% have visited up to 10 different doctors, while around 4% have visited more than 10 doctors to find solution to their symptoms. On economic expenditure regarding doctor's appointments, 47% have spent at least 500 euros, 31% have spent over 500 euros, while 21% have spent nothing. Response on awareness and utilization of long COVID rehabilitation, this one. A response on awareness and utilization of long COVID rehabilitation resources, 27% reported they have undergone post-COVID rehabilitation, 51% have not, while 22% were unaware of such rehabilitation even existed. When asked what kind of care would you prefer, 78% responded a well-organized integrated care and 21% at the nearby primary healthcare center. Similarly, when asked if they have encountered doctors with awareness of long COVID, 46% responded of having encountered doctors who are unaware of long COVID. 25% responded in negation. 28% believes doctors they encountered are aware, but without any active engagement. Most reported, the next slide, please. Most reported symptoms were 70% fatigue, 18% dyspnea, 29% difficulty in concentration, and 28% tachycardia. Hospitalized, next slide, please. Okay, hospitalized and non-hospitalized served the same symptoms, with mental problems higher in hospitalized patients and olfactory disorders 12 times more frequent in non-hospitalized patients. Next slide, please. Our proposal of integrated care. As patient organization, we propose the creation of integrated multidisciplinary referral centers for long COVID with the use of telemedicine and artificial intelligence. These centers will require active involvement and collaboration of state, patient association, and medical communities and universities. Next slide, please. As a patient organization, we want to get involved because we are expert by experience. Our scientific committee and board of directors are scientists suffering from long COVID. We know and can report barriers in the system, acknowledge the problem patients experience. Following our proposal, integrated care, the center should be developed upon 3 axes. One for registration and multidisciplinary evaluation, one for rehabilitation, and one for research. We propose the creation of 7 adult centers in all big cities of Greece and at least 2 pediatric referral centers in Athens and Thessaloniki. All centers must have unified guidelines and share common pathways in accordance with evidence-based medicine and up-to-date practices. The patient referral should be done through one digital platform directing the patient to the nearest center. First contact would be through telemedicine. The patient would be interviewed through the comfort of her house and fill in self-assessment questionnaires. The interview will be recorded and will be available to any doctor involved with the patient. Medical history, along with the patient's answers, will be examined by a team of doctors. A further testing could be requested. As soon as tests are ready, a second appointment will take place person to person, and if not possible, due to distance, for example, it will be facilitated again through telemedicine. Referrals to the center could be made by primary healthcare, private or public, for people with symptoms lasting beyond 12 weeks, vulnerable population like children, students, and elderly, and severely affected. At the referral center, there should be organized rehabilitation services working under the supervision of the multidisciplinary team to meet the patient needs. Whenever possible, rehabilitation should be tied to electronic devices monitoring the patient vitals and accomplices for scientific purposes. All data will be available through the digital platform for research if there is patient consent and ethics approval. Where are we now? Work in progress. First, we need to legitimize long COVID. Unfortunately, after 2 years of pandemic and with dedicated ICD-10 issued by WHO, there is no post-COVID ICD-10 in my country. So this is our priority within this month. At the same time, we need to raise awareness to the public and medical societies. This will be accomplished by launching TV spots, taking part in congresses and webinars. Regarding rehabilitation, we need to make sure it is accessible for all people in need, with no discrimination based on severity of initial infection or need of hospitalization. We have to make sure that insurance policies cover costs. When it comes to involvement of primary care, we need to make sure there is readable education, unified guidelines, and clear pathways in order to recognize people at risk, avoid gaslighting, and empower patients to manage the debilitating symptoms of long COVID. We are working together towards the organization of the first referral centers and want to establish supervision in cooperation with Long COVID Greece. Thank you for your time.
Thank you very much. Eleni, so now we will open the floor for the questions. So I'll just kick off with a question which were already posted in the chat, but feel free to step in the discussion as we go. So there was a first questions from Abigail to Dr. Koulouris about the nutritional screening, as it was felt that it wasn't part of the study that you've conducted, despite of the fact that there has been actually a direct relationship between malnutrition and length of muscle strength. So can you perhaps elaborate on this?
Okay, I have already responded to this question, but what I have to say is that from the medical history, it results that the patients before they get COVID, none of them were malnutrition. But after the COVID, during, as part of the multidisciplinary approach, we have been advised by nutritionists what to do, and the nutritionists have advised also the patients what to do to ameliorate their state. So I think the contribution of nutritionists is essential for the management of these patients. Thank you.
Thank you very much. The other set of questions, actually, two of them were related to data collection and how actually the data that you've been sharing across different systems are shared in the integrated way, and how what kind of infrastructure is in place, and if actually patients can manage the data that has been collected. And there was also a bit of feedback from Philip Webb. Philip, if you don't mind, I would probably bring you on the spot to maybe share with us your experience in Wales with the development of the kind of virtual assistants in this respect, if you don't mind. I found quite interesting.
Yeah, so we're basically developing a Watson virtual assistant to answer a lot of the queries that patients said that they had about how do you live with a disease after you've traumatically had a disease and you've had a really bad experience. So it is really interesting, some of the psychological and emotional impacts of having COVID and then developing long COVID has had quite a profound effect on people. The questions that they're really interested in aren't really covered off from kind of clinical or medical. It's more basic things like how can I manage to walk up and down the stairs because I can't even take 2 steps. So when somebody says to me I should exercise and I can't even move up 2 steps at the moment, at what pace should I manage my physical rehabilitation? What kinds of things should I eat? Am I eating the right or the wrong things? Why do I feel so anxious and depressed about all of this? Why am I being asked to see a whole variety of consultants, not all of whom know what's actually going on with me? So I get referred to cardiology, then I get referred to neurology, then I get referred to a whole variety of different specialties without getting any information back on what's really happening to me. So we're training a virtual assistant that will be deployed for patients freely to be able to answer the questions when they get really anxious. So at 3 o'clock in the morning, when the NHS isn't around, nobody can answer your questions, that's when people get worried about it. So it's really designed to cover off the non-clinical living questions about how I live with long COVID. And it's based around what patients really felt they wanted in terms of practical information to support them. And we're also using it prospectively to collect additional information that they might have not told their medical physician about how they're managing living with the disease. Now, that kind of data is not usually captured on data sets. So it's the subtleties about how people actually are trying to live with a condition that's not frequently captured in the way that we collect data, which is episodic based when somebody has an interaction with a healthcare physician. So what we're trying to do is cover off what people really need to know to live with the fact that they've got long COVID, and largely get passed from pillar to post about where they get good quality information about it. They're also concerned, and this is very interesting about the way that Greece is integrating its care, that having spent time running around the healthcare system, they're still no wiser about what they can actually do with their issues, because they haven't got one place to go to where they can get information either.
Thank you very much, Philip. Any reflections from our colleagues from Greece on this? If not, maybe you want to just kind of like elaborate on that kind of like data sharing and management of data by patients, which was also raised in this relation. Anyone from the speakers can step in. So can patients manage their data by themselves, the one that which are collected, or is it something that is not perceived?
Can you ask the question again, rephrased, so we understand?
Yeah, the question was that how the patient data that are coming from a different system is shared in the integrated models, and if patients can manage their data.
Their data.
Yeah, their data. If they can share their own data, yeah, in any way.
Can I?
Yeah, go ahead, Eleni.
Okay. In the proposed model that we're talking about, data from all doctors and patients would go in the same platform. So data of patients would be accessible to everyone involved in the system. So the patient, all doctors involved with the patient should have access to this data. And if the patient consents, then this data could be used also for research purposes as well. But this is only a suggestion. I mean, we have not, we haven't, it's just our proposal.
Mm-hmm. Great, thank you very much, Eleni. Then there was a question from Diana Whitehouse about, inquiring if there are any important items that can be learned by tracking the patients who have spent some time in the intensive care units, for instance, after discharge in the long-term care. Again, I think it's open question for all the speakers. So any kind of like specific items that you've been kind of like observing that are especially important?
Well, post-ICU people in the long term, unless they have permanent damage in organs, they share the same symptoms as non-hospitalized patients. So by monitoring, for example, their capabilities to exercise, to walk, or to do simple tasks while are connected to, while wearing a smartphone or a smartwatch, you can see how you can collect data, basically data from their heart rate, data from what kind of distances they've managed to walk, or what kind of activities they've done, and then you can see how badly they are affected. So instead of having just self-assessment forms, then you can collect the data from digital watches or smartphones or things like that, and you can assess yourself as a medical doctor the severity of the situation. So it's not just the patient's word, it's data.
Mm-hmm. Excellent. Thank you so much, Eleni. Then there was a specific question about the center that you've created for long COVID. Obviously, it has brought new structures, new systems, new services. And there was a question from Alex: how do you engage citizens and carers? How they are involved, basically, in this work to really enable inclusive, person-centered services and obviously improve their patients' outcomes at the end. So yeah, question is how you engage citizens and carers in the work of the center. Again, any one from the speakers can pick up on this question.
Can I?
Yeah, go ahead, Theo.
Okay, this is a complicated procedure, Andrea, and I think this is the case for many sites in Europe. This is the main reasons that we have asked the contribution of the regional authorities to involve the settings of the primary care, as well as the centers for the social care. So there must be widespread awareness of the people, and there will be an organized way of entering a specific kind of care. I think it's a very important issue for a further discussion to elaborate more.
Mm-hmm. Excellent. And just maybe kind of like a generic question from my side again for all the speakers. You know, obviously as part of this question we picked up on the citizens and their cares, but I think that all the initiatives which you've represented clearly shows that there has been a really engagement of stakeholders and, you know, from various sectors and various disciplines. So I'm just kind of like wondering, you know, do you really think that it's just the COVID-19 who brought all these people together, or would these initiatives be possible regardless of COVID-19? You know, so how do you see the progress forward in terms of the sustainability of these initiatives? Again, I can just, you know, question for all of you, whoever wants to respond.
I can respond to this. I think that the COVID-19 pandemic brought this forward because so far healthcare systems were mainly based on subspecialties, apart from a few exceptions like cancer patients, children with learning difficulties or Down syndromes or things like that. So far, chronic conditions were mostly not receiving that integrated care that they needed. But the COVID pandemic brought forward this problem, and because of the large numbers of people affected at the same time and chronically ill patients, systems are unable to handle this huge amount of patients. So they must start building something new in order to address our problems.
Thank you. Anyone else?
I would like also add, and I agree with Ellen, you know that in Greece there is a lack in primary care, so it's a necessity to utilize the innovative technological methods and devices. The problem is how familiar will be the patients. It depends, of course, to the age, to the IQ, and it's our chance to have this procedure.
Mm-hmm. Thank you very much. And then there was...
Andrea, if I can add a comment on this, the shift from the hospital-centered care to outpatient care must be supported, except of the public authorities, also from the insurance, public or private insurance organization and cover, also to have sustainability of the new services. And this is the most critical point of the new effort in this new era, because it regards the resilience of the whole health and social care system.
Great. Thank you, Theo, for this reflection. Anyone else? No, I then have, I think, another interesting question, which was posed by Andy. If the issue of the obesity and long COVID has been looked into Greece and also perhaps other participants on the webinar. So have you experienced any relationship between the obesity and long COVID patient?
I could speak for for my group. Non-hospitalized patients usually do not fall in this category. Most of us are, mid 40s, okay, athletic with no previous comorbidity. I mean, for example, my only problem was asthma. That is not a great risk factor for anything, but it turns out to be something very important for COVID and long COVID. And also, it's not. I mean, many of non-hospital patients are previously healthy with no comorbidities, athletic types, and it's not all about obesity and poor health. And there are new studies addressing the fact that SARS-CoV-2 could be how do you say that? Could be implicated with allergies. I mean, people with the background of allergies could be at risk of developing long COVID, and that's also a possible mechanism if we took under consideration the mast cell activation syndrome. Okay, thank you.
Thank you. I'm just keeping an eye on time, but I think I'll just pick up on one another question from George Margelis, who mentioned a national personal health record project in Australia, and he's wondering if actually your model in Greece can be used as a mean for collecting secondary data for predictive health decisions or screening.
Can I answer, Andrea? We are currently working on it to use the artificial intelligence approaches to leverage the huge amount of data collected. But so far, we don't have results so far. But I think it's a critical point for our approach to leverage the artificial intelligence possibilities.
Thank you very much, Theo. And I think that this brings us right to the end of this webinar. Thank you so much for very interactive discussions, for really valuable and interesting presentations. As you mentioned, as we mentioned at the beginning, the webinar has been recorded, so you will have the access to the presentations. We will also make sure that there has been the contacts exchanged as per your chat. I would also like to encourage you that if there is any other topic that you wish to explore as part of this knowledge exchange webinars, we would be happy to take them on the board and prepare another series of this webinar. And yeah, just please get in touch with us whenever whenever you feel that there is such an opportunity. So thank you so much to all our speakers, to all our participants, and we look forward to welcoming you at our next webinar. Thank you so much.
Thank you for that. Thanks, Adriana. And just a quick word from myself. Thanks to all colleagues from Scotland for the hard work and dedication in building this. Great to see all the colleagues from Greece here today. Fantastic to see all of you. Again, some of you and some of you I've not met before. I think there's a lot of collaboration going on in the chat function. We can help turn some of that into some resources as well, because we've got presentations, we've got videos, and I think what we'd like to do, there's some resources been shared in the chat function from Scotland and Wales. We will build that and put that back up onto our platform. We're able to do that now where we couldn't do before. So this won't be wasted. So Phil, George, etc., we can continue this conversation afterwards with you, Diane, as well. So thank you for all your kind time and resources. Thanks for the
Thank you.
time
Thank you
today,
very much.
and lovely to speak to you all. This is about collaboration. Let's keep that conversation going.
For the opportunity you gave us to.
Thank
you so much. Goodbye.
Goodbye.
Well, thank you. Goodbye.
Thank you, Theo.